open for discussion and questions.
I'll take the first question, if I may, Professor Frey. Thank you for this very erudite talk, and especially the exciting one on neuroinflammation and the epileptiform foci with cellular infiltration and activation. I was wondering if there is a SPECT technique, either inflammation imaging or a PET technique such as a gallium-68 PET for inflammation imaging that can show us epileptiform foci with inflammatory disease, which are actually supposed to be the one when they're activated, or the potential of that. Thank you.
So as you know, as I'm sure we all know, there are localization studies particularly done with perfusion SPECT imaging that can show us, comparing the patient at the onset of a seizure with the patient while seizure-free, that can show us increased perfusion due to the epileptic discharge. And that's, so ictal SPECT versus interictal SPECT, and when processed carefully, this can be nicely predictive of where the seizure onset zone is and what perhaps should be resected. I think, though, that the ability to do inflammation imaging may allow us very early in the course of epilepsy to predict which patients are not going to respond to anticonvulsant therapy and might be referred to surgical treatment rather than waiting the 2 or 3 years to fail a number of anticonvulsants. So I think the persistent presence of an inflammatory milieu with the abnormal biochemical products may predispose to epilepsy that is not going to favorably respond to medical therapy. And for that, we don't yet have a clinically available tracer, but I think these TSPO ligands may work for that. And I'm pretty certain that the tryptophan derivative will work, but that's a carbon-11 compound, and therefore you have to have an on-site cyclotron to use it.
In my experience with previous experience with perfusion scanning is not very but it's not very successful in the interictal and ictal scans that have done in the past, the few ones that have done. However, is there any relationship between the inflammation and the ictus per se?
So again, this is an area where I think there are no data. In our laboratory, we have not yet applied this approach, so I have no experience specifically with comparing the ictal onset zone with the inflammation. Dr. Chugani, who's 50 or 60 miles from us, would argue aggressively, but based on anecdotal evidence, that the AMT-defined lesion is what must be surgically resected to stop the seizures in his series of tuberous sclerosis patients.
Yes, I mean, that seems to suggest that. Thank you. Questions from the audience, please?
Thank you for the nice presentation with probably future hope for radio traces. There is now an entity that is being talked about, which is the paraneoplastic encephalitis, and this is like a lot of time nuclear medicine is called upon to, and Dr. Sharjeel here, he knows about it. We saw a case only recently. Now, would that be something that we probably should look into when we do PET scanning in cancer patients, in your experience?
So you bring up a very interesting and, of course, very controversial area. So the notion that patients with underlying malignancies may have, we think, an antibody-mediated attack on certain specific brain areas, and I would assume, but I have no independent evidence, that the brain response is an inflammatory process, at least in its initial manifestation. So there are many paraneoplastic syndromes which include attacks on the cerebellum or on the limbic system or even on peripheral nerves, sensory neuropathy in particular, that are associated with identifiable autoantibodies if you take plasma from the patient and look for them. My assumption would be that they would be identifiable in terms of the brain effect by looking for inflammation if we had a good way of doing this. The other condition, though, is non-neoplastic or non-paraneoplastic, and that is the condition of steroid-responsive encephalopathy, if you're familiar with this. This is a condition that is also relatively controversial. Some clinicians believe it doesn't exist, and others rely on it heavily. But this is associated with thyroiditis and antimicrosomal antibodies. And in some patients who have those circulating antibodies, they develop cognitive impairment, fluctuating mental status, and even seizures that respond to high doses of corticosteroids, and where it's believed the mechanism is you are suppressing the secondary inflammatory effects of those antimicrosomal antibodies and their effect on the brain. So there are a host of conditions that are not very well understood that might very well be advantaged in terms of our understanding by a specific and sensitive way of imaging inflammatory activity in the brain.